The next cause of hypoxia we want to think about is pulmonary hypoxia. Now, the main function of the lungs is to get oxygen from the outside air into the blood, and of course carbon dioxide from the blood back into the outside air. So any time the lungs are unable to perform this function, or unable to perform this function adequately, there can be a pulmonary hypoxia. Hypoxia which occurs as a result of lung malfunction. And this can be caused by lung disease, or it can be caused by lung trauma. And of course we come across many lung diseases in routine practice. Bronchial asthma, for example. In this condition there is inflammation in the bronchioles, in the small airways. And the inflammation leads to swelling, increased mucus production which clog up the small airways, and bronchoconstriction. And all of these make it much harder for the air to get into the alveoli. And it also makes it much harder for the air to get out of the alveoli. So once the air's in the alveoli, the oxygen's absorbed and the amount of carbon dioxide increases, that air needs to be exhaled. And if the small airways are obstructed, that becomes much more difficult. And the lung actually becomes hyperinflated with what you might call stale gases. Gases which are low in oxygen and high in carbon dioxide, which need to be breathed out. And that becomes very difficult in asthma. And that leads to hypoxia. Pneumonia, severe chest infections. Pneumonia is infection of the lung tissue. It is infection at the level of the alveoli. An infection at that level leads to inflammation and the formation of inflammatory exudates that can fill up the alveoli. And if the alveoli are full of inflammatory fluids and bacteria and white blood cells and fibrin, then clearly if they're full of all these things, the oxygen can't get in, and the oxygen and gaseous exchange processes aren't going to work in pneumonia. In lung cancer, you can get obstruction of some of the larger airways. Chronic obstructive pulmonary disease, we get lots and lots of that in England. Bronchitis and emphysema are the main components of chronic obstructive pulmonary disease. There can be a chronic asthmatic component as well. In bronchitis, there's chronic inflammation and infection in the bronchial passages, the trachea and larger bronchial passages. And in emphysema, there is a destruction of the alveolar membranes with loss of elasticity in the membranes of the alveoli. Cystic fibrosis, where you get viscous pulmonary secretions. All of these things can lead to reduced lung function and pulmonary hypoxia. Pulmonary edema could be another one. In left ventricular failure, pulmonary edema can develop, and the lungs have got get too much fluid in them. It's a bit of a similar mechanism, I suppose, to that high altitude condition we talked about. Remember the high altitude pulmonary edema? But if there's edema in the tissues of the lung, again, that means there's fluid. That means the oxygen can't get in effectively. Respiratory distress syndrome in premature babies, where there's insufficient surfactant to allow the absorption of oxygen, will lead to a pulmonary hypoxia. Thinking about trauma, lung collapses. Penetrating chest trauma can lead to a pneumothorax. Of course, you can get a spontaneous pneumothorax as well. It tends to occur in thin, tall young men, but not exclusively. And in a spontaneous pneumothorax, there's a rupture in the visceral pleural membrane, and that can allow air from inside the lungs into the pleural space. Spontaneous pneumothorax. The patient becomes breathless, and if you listen to the lung with a stethoscope, the air entry, you can't hear the air entry because the lung is collapsed. So the normal air entry that you would hear going through the bronchial passages, that is gone. And when you percuss, there's a hyperresonance. The note is more hollow than normal because there's less lung tissue present. and that often needs treated with an underwater sealed drain. Same as a traumatic pneumothorax. With penetrating chest trauma, air can get from the outside world into the potential pleural space, and of course that converts the potential pleural space into an actual pleural space. The air takes up that space, and that collapses the lung. In trauma, you can get blood into the pleural space as well. Patients can lose a lot of blood. They can become shocked and hypovolemic due to bleeding into the pleural space. That would be a hemothorax. And in trauma, you can often get blood and air in the pleural cavity, a hemopneumothorax. In some malignant diseases, in lung cancer, you can get a lot of malignant inflammatory exudates in the pleural space, and that can fill up with that watery fluid. It's called a hydrothorax. All these things can collapse the lung, leading to a pulmonary hypoxia. Let's go on now and talk about anemic hypoxias. Now, an anemic hypoxia is any hypoxia caused by a reduced oxygen carrying capacity of the blood. Because remember, we said that hypoxia is a lack of oxygen at the level of the tissues. So for the oxygen to get to the tissues, it must be carried from the alveoli in the red cells of the blood to the tissues. And whenever the red cells are defective or inadequate in numbers, then they're not going to be able to carry the oxygen from the alveoli to the cells of the body. So any form of anemia can lead to an anemic hypoxia. Globally, by far and away the most common form of anemia is iron deficiency anemia. This affects a very sizable proportion of the world's population, because iron is absolutely essential for the formation of the hemoglobin molecules. At the core of every hemoglobin molecule is iron. So lack of iron leads to iron deficiency anemia. Folic acid and B12 are also essential. Hemolytic anemias, where there's too much hemolysis, where the red blood cells are broken up too quickly. You get this when, usually these are genetic things, so you get it in things like sickle cell disease or thalassemia or spherocytosis, where either the red cells are the wrong shape or the hemoglobin molecules are abnormal. And these abnormal cells are broken down by the monocyte macrophage system, mostly by macrophages in the spleen, but also by macrophages in the liver. The old-fashioned name for that, you might read, is the reticuloendothelial system for these cells that break down old red blood cells. Hemorrhage is a cause of anemia, especially if there's chronic bleeding, ulcerative colitis perhaps, or fibroids, where there's a menorrhagia and excessive blood loss during menstruation. Because if the blood cells are lost more quickly than the red bone marrow can make them back again, then anemia is going to develop. It's quite easy to replace the fluid component of the blood in chronic hemorrhage. You just drink and the fluid component is replaced, but it takes longer to produce the red blood cells. So while the blood volumes might be normal, the amount of red cells in the blood can be reduced. Anemic hypoxia can be caused by carbon monoxide poisoning. Carbon monoxide forms a stable compound with hemoglobin called carboxyhemoglobin, and carboxyhemoglobin won't carry any oxygen. The oxygen carrying sites are occupied by carbon monoxide. That can occur in people that smoke cigarettes, or people that have been exposed to smoky environments. It will dissociate over a few days. When people stop smoking, they get their breath back, or so-called get their breath back. Their respiratory function improves significantly over about a week. Well, not so much the respiratory function, but they feel less breathless because the oxygen is carried much more efficiently in their blood as they get rid of the carbon monoxide, and that allows the hemoglobin molecules to carry oxygen again the way they're supposed to. The next classification to think about is stagnant hypoxia, and this is caused by relative stagnation of the circulatory system, where the blood is not circulating as it should to transport the oxygen. In congestive cardiac failure, for example, the blood is not circulating around the body as it's supposed to. Or in shock, there's a deficiency of the circulatory system. So if the circulatory system is not working properly, blood is not being pumped around the body as it should be. It's not able to circulate the red cells adequately. So there's going to be a stagnant hypoxia. And you could include shunting in this. There's a couple of congenital disorders here. Atrial septal defects, for example, what's called a hole in the heart, where the communication between the atria doesn't close at birth as it's supposed to, and you can get mixing of the oxygenated and deoxygenated bloods between the right and the left atrium. Well, there's another one that you might come across called patent ductus arteriosus. Again, in fetal life, there's a communication between the pulmonary artery and the aorta, and if that doesn't close off properly, again you can get mixing of the blood between the pulmonary and the systemic sides of the circulation. And there's lots of localized causes of stagnant hypoxia as well, where there's inadequate perfusion of a particular tissue and ischemia. You could call this an ischemic hypoxia, but it normally comes under the stagnant classification. So in intermittent claudication, for example, there's not enough blood supply going to the limbs, to the legs. In angina, stable angina, angina pectoris, there's not enough blood going to the myocardium. If there's not enough blood going to the tissues, that means there's not enough oxygen going there. Cerebral transient ischemic attacks can be caused by cerebral hypoxia. And then there's local pressure effects as well. One classic one here is you might put a plaster of Paris on someone, and then the inflammatory process continues, and you get swelling within the plaster cast, and that causes localized pressure effects, which can cut the blood supply off to the limb. So we always have to make sure that our patients' limbs are adequately perfused with blood, otherwise they won't be getting their oxygen supply. Tissue edema is another cause of stagnant hypoxia. If there's too much fluid in the tissue spaces, then what that does, it increases the diffusional distance that the oxygen has to go through, and it can reduce the amount of oxygen that gets to the tissue cells and reduce the viability of the tissue cells. Anyway, the last classification of hypoxia is histotic hypoxia. Now, in histotic hypoxia, the blood gets to the oxygen, gets to the cells as it's supposed to, but the cells are unable to use it. And this can happen in cyanide poisoning. That blocks the process of respiration. It stops the energy production. But other things can reduce the efficiency of energy production in the mitochondria. Lack of vitamin Bs can. Alcohol and carbon monoxide can both reduce the efficiency of the process. It's a histotic hypoxia because even though the oxygen is getting to the tissues of the body aren't able to use it adequately.